We've already discussed the epi triangle and the levels of prevention intervention, but I want to reiterate a few things because they're important to epidemiology. Epidemiologists understand that disease results from complex relationships among the agent, persons, and environmental factors. These three elements are the agent, host, and the environment. The agent is an inanimate or animate factor that must be present or lacking for a disease or condition to develop. Agents are infectious agents like bacteria, virus, fungi, and parasites, chemical agents like heavy metals, toxic chemicals, or physical agents like radiation, heat, cold, machinery. A host is a living species, human or animal, capable of being infected or affected by an agent. Hosts have genetic susceptibility, immutable characteristics like age or sex. They have acquired characteristics such as immunological status, and they have lifestyle factors like diet, exercise, or wearing your seatbelt. The environment is the last part of the triad or triangle. All that is internal or external to a given host or agent and that is influenced or influences the host and or agent. Examples of an environment are the climate, which is the temperature or rainfall, plant and animal life, human population distribution, such as crowding or social support, socioeconomic factors like education, resources, or access to care, and working conditions like levels of stress, noise, or satisfaction. The term web of causality recognizes the complex interrelationships of many factors interacting, sometimes in subtle ways, to increase or decrease the risk for disease. Also, associations are sometimes mutual, with lines of causality going in both directions. Recently, some researchers advocated for a new paradigm that goes beyond the two-dimensional causal web and considers multiple levels or factors that affect health and disease. This is consistent with the ecological model for population health, which was supported by many people. The ecological model treats the multiple determinants of health as interrelated and acting synergistically or antagonistically rather than a discrete factor. The goal of epidemiology is to identify and understand the causal factors and mechanisms of disease, disability, and injuries so that effective interventions can be implemented to prevent the occurrence of these adverse processes before they even begin. The natural history of disease is a course of disease process from onset to resolution. There are three levels of prevention: primary, secondary, and tertiary, that provide a framework often used in public health practice. Primary prevention refers to interventions that promote health and prevent the occurrence of disease, injury, or disability. Primary prevention is aimed at individuals and groups who are susceptible to a disease but have no discernible pathological process. Secondary prevention refers to interventions designed to increase probability that a person with a disease will have the condition diagnosed early enough that treatment is likely to result in a cure. Health screenings are at the core of secondary preventions. Early and periodic screenings are critical for diseases such as breast cancer, for which there are few specific primary prevention strategies. Screening programs are discussed in future sections. Tertiary prevention includes interventions aimed at limiting disability and interventions that enhance rehabilitation from disease, injury, or disability. Interventions for tertiary prevention occur most often at secondary and tertiary levels of care, but also occur at community and primary care settings. Examples of tertiary prevention are medical treatment, physical and occupational therapy, and rehabilitation. Screening is a component of many secondary prevention interventions, and it involves the testing of groups of individuals who might be at risk for a specific condition, but they might not have a symptom. The goal is to determine the likelihood that these individuals will develop the disease. From a clinical perspective, the aim of screening is early detection and treatment when the result in a more favorable prognosis. From a public health perspective, the objective is to sort out efficiently and effectively those who probably have the disease from those who probably do not. Again, to detect early cases for treatment or to begin public health prevention and control programs. A screening test is not a diagnostic test. Effective screening programs must include referrals for diagnosis, evaluation for those who have positive findings or screenings. Nurses actually have to stay very current on screening guidelines because they are regularly reviewed and revised. Reliability is a key component of screening. It is important to pay attention to the precision or the reliability of a measure and the accuracy of the measure. When we talk about reliability, there are three major concerns for reliability. It can be variation that is inherent in the trait being measured. It can be observer variation, which can be divided into intra-observer reliability or inter-observer reliability. We can also look at reliability in terms of the consistency of the instrument, which includes the level of internal consistency of the instrument that we are using to do the screening. Validity in a screening test is typically measured by sensitivity and specificity. Sensitivity quantifies how accurately the test identifies those with the condition or trait. Sensitivity represents the proportion of persons with the disease whom the test correctly identifies as positive, or what we know as true positives. High sensitivity is needed when early treatment is important and when identification of every case is important. Specificity indicates how accurately the test identifies those without the condition or trait. High specificity is needed when rescreening is impractical and when it is important to reduce false positive results. The sensitivity and specificity of a test are determined by comparing the test results with results from a definitive diagnostic procedure. The ideal for a screening test is 100% sensitivity and 100% specificity. That is, the test is positive for 100% of those who actually have the disease and is negative for 100% of those who do not. In practice, sensitivity and specificity are often inversely related. A third measure associated with sensitivity and specificity is the predictive value of the test. The positive predictive value is the proportion of persons with a positive test who actually have the disease, interpreted as the probability that an individual with a positive test has the disease. The negative predictive value is the proportion of persons with a negative test who are actually disease-free. Descriptive epidemiology describes the distribution of disease, death, and other health outcomes in a population according to person, place, and time. The type of epidemiology provides a picture of how things are or have been and describes who, where, and when the disease is occurring. In contrast, analytic epidemiology looks for the determinants of the patterns observed, the who, how, and the why. When we talk about personal characteristics, we're talking about the age, education, occupation, income, marital status, anything that can describe the person. Age is actually the most important predictor of overall mortality. The mortality curve by age drops sharply during and after the first year of life and is at a low point through childhood, then begins to increase through adolescence and young adulthood, and after that increases sharply through middle age and older ages. When we talk about time, when we talk about place, we are looking at the distribution of disease and we examine geographic patterns. Does the rate of disease differ from place to place? If geography had no effect on disease occurrence, random geographic patterns might be seen, but that is not often the case. An example is high altitudes and alcohol tension and oxygen tension is lower, which might result in smaller babies. Time is the third component of descriptive epidemiology. In relation to time, epidemiologists ask these questions. Is there an increase or decrease in the frequency of the disease over time? Are there temporal or spatial patterns that are evident? Temporal patterns could include secular trends, point epidemics, or cyclical patterns. Secular trends are long-term patterns of morbidity or mortality. They actually reflect changes in social behaviors or practices. A point epidemic is a time and space-related pattern that is important in infectious disease investigations and is an indication or an indicator for toxic exposures. A point epidemic is most clearly seen when the frequency of cases is graphed against time. The goal of analytic epidemiology is to discover the determinants of outcomes, the how and the why. Cohort studies are the standard for observational epidemiological studies. It comes closest to the idea of natural experiment. The term cohort is used in epidemiology to describe a group of persons who are born at about the same time. In analytic studies, cohort refers to a group of persons generally sharing some characteristic of interest. They are enrolled in a study and followed for some time. In a prospective cohort study, subjects who do not have the outcome under the investigation are classified on the basis of the exposure of interest at the beginning of the follow-up period. The subjects are then followed for some period of time to determine the occurrence of disease in each group. The question is, do persons with the factor or exposure of interest develop or avoid the outcome more frequently than those without the factor or exposure? Retrospective cohort studies combine some of the advantages and disadvantages of case control studies and prospective cohort studies. These studies rely on existing records such as employment, insurance, hospital records to define a cohort that is classified as having been exposed or unexposed at the same period of time. The cohort is followed over time using the records to determine the outcome that occurred. In a case control study, subjects are enrolled because they are known to have the outcome of interest. Case control status is verified using a clear case definition and some previously determined method or protocol, or by an examination, lab test, or medical chart review. Information is then collected on the exposures or characteristics of interest frequently from existing sources, subject interviews, or a questionnaire. Cross-sectional studies provide a snapshot or cross-section of a population or group. Information is collected on current health status, personal characteristics, and potential risk factors or exposures all at once. In the cross-sectional study, there are simultaneous collection of information necessary for the classification of exposure. Historical information can also be collected. Ecological studies is a bridge between descriptive and analytic epidemiology. The descriptive component looks at variations in disease rates by person, place, and time. The analytic component tries to determine if there is a relation of disease rates to variations in rates for possible risks, factors, or characteristics. The identifying characteristic of ecological studies is that only aggregate data, such as population rates, are used rather than data on individual exposures, characteristics, outcomes. We also have clinical trials, which are experimental studies. The goal of a clinical trial is generally to evaluate the effectiveness of an intervention, such as a medical treatment for disease or a new drug or an existing drug. In clinical trials, subjects should be randomly assigned to groups. We also have community trials that are similar to clinical trials. However, in community trials, they often deal with health promotion or disease prevention rather than treatment of an existing disease. The intervention is usually undertaken on a larger scale, and the unit of treatment is a community, region, or group rather than an individual. Sample size, strength of association, and variance of measures can all affect statistical significance. For example, to determine if eating habits affect the onset of hypertension, a statistical association between the factor, the diet, and the health outcome, hypertension, would need to be established. If the probability of the disease seems unaffected by the presence or level of the factor, no association is apparent. If, on the other hand, the probability of the disease does vary according to whether the factor is or not present, there is a statistical association. A statistically significant result may be observed because of a bias, a systematic error as a result of the study design, the way that it was conducted, or a confounding factor. Bias can occur in a selection or the way that the subjects enter the study. Selection bias has to do with selection procedures and the population from which subjects are drawn, and it may involve self-selection factors. And examples are teenagers who agree to complete a questionnaire on alcohol, tobacco, and other drugs used. Are they actually representative of the total teenage population? We can also have a misclassification of subjects once they are in the study. This is information or classification bias. It is related to how information is collected, including the information that the subjects supply or how subjects are classified. Confounding or bias resulting from a relationship between the outcome and study factor can also occur. The existence of statistical association does not necessarily mean that a causal relationship exists or that causality is present. As just discussed, the observed association may be a random event due to chance, or may be the result of bias from confounding or from some aspect of the study design or execution. Statistical associations, although necessary to an argument for causal inference, are not adequate proof. Some epidemiologists refer to guidelines, the term originally established to evaluate the link between an infectious agent and a disease, but revised and elaborated to apply to other outcomes.